Welcome back to the Stroke Made Simple channel, and today we're talking about brain aneurysms. So before we start, I'm going to break this lecture up into three components, seeing there's a lot of material here. And remember, this is all covered in the book, so if you enjoy the content of this video, please click the like and subscribe button. So we're going to do three parts, and today's video will review the first part, or an introduction to brain aneurysms and certain other aspects of them, such as imaging and CSF analysis. Part 2 we'll cover in our next video, which will discuss clinical management. Part 3 will discuss different treatment options. So to be more specific, what we're going to discuss today is an introduction to brain aneurysms, their etiology, their clinical presentation, CSF analysis, and imaging. On the next video, we're going to talk about clinical management involving high blood pressure, hydrocephalus, seizure, neurogenic stunned myocardium, vasospasm, diabetes insipidus, hyponatremia. We're going to talk about this epic battle between SAEDH and CSW, and finally osmotic myelinolysis. And then the third lecture, or third video, we'll wrap up specifically discussing treatment and really discussing open surgical clipping versus minimally invasive endovascular techniques. So let's go ahead and start. So today we're talking about subarachnoid hemorrhage caused by ruptured intracranial aneurysms. Remember, this is a form of hemorrhagic stroke. When subarachnoid hemorrhage is caused by ruptured brain aneurysms, we call this aneurysmal subarachnoid hemorrhage. So when you see this little ASAH, this means aneurysmal subarachnoid hemorrhage, or subarachnoid hemorrhage caused by a ruptured brain aneurysm. So what are brain aneurysms? Brain aneurysms are focal expansions or outpouchings of the cerebral arteries. They're commonly referred to as berry aneurysms because they usually have a berry-like shape. So if you look at this depiction of this aneurysm, looks like a berry, just like this blueberry. Here's an angiogram of a basilar tip aneurysm, and look at this, looks just like this blueberry. By the way, what else do we see here in addition to this aneurysm? We see a lot of anatomy. Here are both vertebral arteries forming the basilar artery. Before they do, they give off the posterior inferior cerebellar artery. After they form the basilar artery, they give off the anterior inferior cerebellar artery, which makes this curlicue pattern. Next major vessel is the superior cerebellar arteries, and then the basilar artery bifurcates into two posterior cerebral arteries. This is a basilar tip aneurysm. Remember, brain aneurysms occur at arterial branch points, particularly around the circle of Willis, and we discussed this in the last lecture. Now remember, the circle of Willis is located at the base of the brain. So here's the brain, here's the circle of Willis where all these little aneurysms can occur. But remember, when an aneurysm ruptures, it bleeds into the subarachnoid space, which encompasses the entire brain and spinal cord. So these high pressure aneurysmal subarachnoid bleeds can be dispersed diffusely throughout the covering of the brain and the spinal cord, specifically within the subarachnoid space. Now, what causes brain aneurysms? Well, we believe it's a combination of prolonged hemodynamic stress and alterations in flow that cause these aneurysmal lumens to grow. Because we believe this occurs over time, these are termed sporadic acquired lesions. And just like this bleb on this tire is an acquired lesion. When this person bought their car, this bleb wasn't here, but there's probably a focal weakness in the tire that causes it to expand and grow, just like a brain aneurysm. Now, 12 million Americans have brain aneurysms. Fortunately, the vast majority of these are small and won't rupture. Now, there are other medical conditions that can be associated with brain aneurysms, such as polycystic kidney disease, fibromuscular dysplasia, Marfan syndrome, Ehlers-Danlos, and brain arteriovenous malformations. Now, why are these conditions associated with brain aneurysms? Again, we believe these conditions weaken the vascular wall integrity, allowing aneurysms to form. Now, Marfan syndrome is a connective tissue disorder characterized by unusually long limbs, and it was believed to have affected Abraham Lincoln. Ehlers-Danlos syndrome is characterized by stretchy skin and very loose ligaments and joints. But in either case, what we're talking about really, when we're talking about the formation of brain aneurysms, the associated conditions, is a weakening in arterial wall that will enlarge into an aneurysm, just like blowing up this balloon. So ruptured brain aneurysms cause aneurysmal subarachnoid hemorrhage. This is a form of hemorrhagic stroke. Remember, hemorrhagic stroke accounts for 3% of all stroke. Aneurysmal subarachnoid hemorrhage accounts for 3% of all stroke cases. It's the most common cause of non-traumatic subarachnoid hemorrhage. The most common cause of subarachnoid hemorrhage is trauma. That's going to be a separate lecture, separate video. Again, remember the circle of Willis, it sits on the base of the brain. It connects the anterior and posterior circulation. But even though it's on the undersurface of the brain, a ruptured aneurysm, when it bleeds into the subarachnoid space, which communicates with all the covering of the brain as well as spinal cord. So the incidence of aneurysmal subarachnoid hemorrhage in the United States is one case per 10,000 people, or 27,000 cases per year. The peak incidence is 55 to 60 years old, and aneurysmal subarachnoid hemorrhage is more common in women than men. Aneurysmal subarachnoid hemorrhage has a 30-day mortality rate of 45%. That's pretty high, with 30% of survivors suffering moderate to severe disability. That's pretty high too. Now, people who have ruptured aneurysm have this characteristic presentation where they say they have experienced the worst headache of my life. Now, this is interesting because most ischemic stroke is painless, except for dissection-related strokes. So strokes caused by carotid or vertebral artery dissection can be accompanied with neck pain and headaches. But again, most ischemic stroke is not associated with headaches, and it's certainly not the worst headache of my life. So when you hear the worst headache of my life, think of a ruptured brain aneurysm. You should always be thinking of that. Now, there's a mnemonic for ischemic stroke, the Be Fast mnemonic, that alerts us to sudden changes in balance, vision, facial asymmetry, arm or leg weakness or numbness, and speech disturbances. Any sudden signs or symptoms involving balance, eyes, face, arm, or speech mean it's time to dial 911 immediately. Now, the T typically stands for time to dial 911, but if we make T terrible headache, sudden onset of a terrible headache, now we can include a ruptured brain aneurysm or hemorrhagic stroke in this ischemic stroke mnemonic. In fact, this terrible headache, remember, is described as the worst headache of my life. So aneurysmal subarachnoid hemorrhage has a rule of thirds, and this rule of thirds says 1/3 of these patients die before reaching the hospital, 1/3 will have permanent neurological deficits, and 1/2 of the last third will have minimal or no permanent disability. The clinical presentation of aneurysmal subarachnoid hemorrhage is dependent on the volume of blood within the subarachnoid space and the mass effect of this blood around surrounding brain tissue structures. Clinical severity is the strongest predictor of functional outcome, and the way we determine the clinical severity is we use a grading scale called the Hunt-Hess grading scale, named after this extremely famous physician, William Edward Hunt, who also described Tolosa-Hunt syndrome. Today we're just discussing the Hunt-Hess scale. Again, this is a grading scale for aneurysmal subarachnoid hemorrhage. Grade 1 is used for patients who are asymptomatic or have a mild headache. Grade 2 indicates moderate to severe headache or oculomotor palsy. Grade 3, patients are confused, drowsy, or have mild focal signs. Grade 4, the patient stuporous and localizes the pain. Grade 5, these are patients who are in a coma, who either posture or have no motor response. So if we look at these higher grade patients on the Hunt-Hess scale, greater than 4, these 4s and 5s, they unfortunately have mortality rates greater than 70%. Most intracranial ruptured brain aneurysms have a central distribution. We discussed this in the last lecture. Why? Because within this suprasellar cistern which we see here that's filled with subarachnoid hemorrhage, lies the circle of Willis. So because the circle of Willis sits in the middle of the supraciliary cistern and is a frequent source of brain aneurysms, a ruptured brain aneurysm in the circle of Willis is going to bleed into the supraciliary cistern and cause this characteristic star-like bleeding pattern. Remember what some normal anatomy last time too? This is the fourth ventricle here. This is the prepontine cistern. This is the supraciliary cistern. This is the level of the pons. One cut higher at the level of the midbrain. Laterally, this is the ambient cistern. Posteriorly, this is the quadrigeminal plate cistern. Remember, the circle of Willis is a frequent source of brain aneurysms, and it sits right in this supraciliary cistern. In fact, you can imagine it sitting right here. Again, frequent source of aneurysms. So if this ruptures, you can get bleeding in the subarachnoid space in the supraciliary cistern. And by the way, let's go over this anatomy really quick. Here are both vertebral arteries. Before they form the basilar artery, they give off the posterior inferior cerebral artery. After they form the basilar artery, they first give off the anterior inferior cerebral artery, followed by the superior cerebral artery, and the basilar artery bifurcates into two posterior cerebral arteries. Don't forget these pontine perforators between the anterior inferior cerebral artery and the superior cerebral artery. Also, remember the posterior cerebral arteries connect to the anterior circulation via two posterior communicating arteries. So one way we can grade subarachnoid hemorrhage based on imaging is something called the Fisher scale. And the reason the Fisher scale is so important is it is predictive of developing symptomatic cerebral hemorrhage, symptomatic cerebral vasospasm. Specifically, the higher the Fisher scale, the greater chance of developing symptomatic cerebral vasospasm. So in this scale, a 0 is no subarachnoid hemorrhage. Grade 1 is no subarachnoid hemorrhage, Grade 2 is diffuse subarachnoid hemorrhage less than 1 millimeter thick. Grade 3 is diffuse subarachnoid hemorrhage greater than 1 millimeter thick. And grade 4 is subarachnoid hemorrhage with either intracerebral hemorrhage or intraventricular hemorrhage. Remember, the higher the grade, the greater the chances of developing symptomatic cerebral vasospasm. Now, the mortality rate of aneurysmal subarachnoid hemorrhage and any type of intracerebral hemorrhage for that matter can be predicted by using the intracranial hemorrhage or ICH score. And this consists of evaluating the Glasgow-Coma scale, the presence of intracranial hemorrhage volume, intraventricular extension, infratutorial location, and age. Now, let's shift and talk about cerebral spinal fluid analysis. So we analyze cerebral spinal fluid or obtain it via lumbar puncture, and this analysis can diagnose subarachnoid hemorrhage. A lumbar puncture should typically be performed 6 hours after symptom onset because that'll allow the blood cells that are distributed in the brain subarachnoid space to descend into the subarachnoid space of the lumbar region. 4 separate sterile tubes are required for analysis, specifically looking for red blood cell count in all 4 tubes. Another thing we can see here, and you see here like this yellowish fluid here, is these are degraded red blood cell products that over time become this yellow fluid, and this is termed xanthochromia. So this is normal, clear CSF. This yellow tint CSF is called xanthochromia, caused by degraded red blood cell products from a prior subarachnoid hemorrhage. Consistently high red blood cell counts in all 4 tubes and the presence of xanthochromia, those degraded red blood cell products, are indicative of subarachnoid hemorrhage. Xanthochromia is detected 2 ways, by either spectrophotometric analysis, which has a specificity of 97%, or visual inspection, which has a specificity of only 29%. This is less than flipping a coin. So really, if you're doing these studies, you really need spectrophotometric analysis. Xanthochromia is present in nearly 100% of all cases of subarachnoid hemorrhage after 12 hours and still remains present in 70% of all cases at 3 weeks. Another reason the spectrophotometric analysis is very important is, like, look at this example here. This is xanthochromia. It's very hard to delineate that from clear cerebral spinal fluid. So again, we don't want to use visual inspection. We want to use spectrophotometric analysis. A traumatic tap initially contains no xanthochromia, because remember, there's no degraded blood products yet, red blood cell products yet. But you can have xanthochromia from prior traumatic taps. So if you try to do a tap a day before it's traumatic, those red blood cells can degrade and form xanthochromia. But typically, acute traumatic taps do not contain xanthochromia. Therefore, any blood-tinged lumbar puncture performed after 12 hours without xanthochromia, okay, that is confirmed by spectrophotometric analysis, should be considered traumatic. So this tap that's red, has red blood cells in it, that does not contain xanthochromia, should be considered traumatic. Again, having consistently high red blood cell counts in all 4 collection tubes with xanthochromia is indicative of subarachnoid hemorrhage. A traumatic tap has many red blood cells in the first collection tube, but these diminish over the subsequent tubes. So the first has the most, the second has the second most, third, fourth have less and less red blood cells. So we have 4 situations. If we have clear cerebral spinal fluid, this is normal. If we have consistently high red blood cell counts in all 4 tubes, this is subarachnoid hemorrhage. Xanthochromia is also indicative of subarachnoid hemorrhage. And if we have tubes where the first tubes have more red blood cells and they become less and less in further tubes, this is a traumatic tap. This kind of reminds me when we used to watch Sesame Street, but in this case, instead of one thing being different, 3 things are different, and the one thing being different here is the normal cerebral spinal fluid. Here we have, this is normal clear cerebral spinal fluid. Here we have subarachnoid hemorrhage, red blood cells consistently high in all the tubes with xanthochromia. This is subarachnoid hemorrhage with just xanthochromia, and this is a traumatic tap with high blood cells, red blood cell count in the first tube, diminishing thereafter. So, cerebral spinal fluid analysis with a high number of red blood cells and xanthochromia in all 4 tubes is consistent with subarachnoid hemorrhage. To effectively test for subarachnoid hemorrhage, 4 CSF collection tubes and spectrophotometric analysis is always necessary. Why spectrophotometric analysis is always necessary? Well, look at these. How are you going to tell if these have xanthochromia with visual inspection? You can't. You need spectrophotometric analysis to determine the presence of xanthochromia. So when we look at subarachnoid hemorrhage, all 4 tubes have the same amounts of red blood cells, and there's xanthochromia. When we look at traumatic lumbar punctures, we have diminishing red blood cells per collection tube, and there is no xanthochromia. So CSF analysis is useful in patients who arrive in the hospital days after their symptom onset. Why? Because days later, the sensitivity of CT diminishes to detect subarachnoid hemorrhage. However, CSF analysis is still fairly sensitive. This is particularly relevant in people that have sentinel bleeds or sentinel headaches. And this is thought to be caused from a small bleed from an aneurysm that causes a severe, worst headache of their life presentation. And then the patient comes to the hospital days later. They likely had a bleed days later that is dissipated, but is no longer seen on CT scan. Brain CT is very sensitive for acute subarachnoid hemorrhage. It has 100% sensitivity to detect subarachnoid hemorrhage within 5 days of symptom onset. CSF analysis, one study showed, had no additional value in patients presenting with acute headaches and a normal head CT within 6 hours of symptom onset. So their head CT was normal. These authors concluded they could effectively diagnose subarachnoid hemorrhage with CT alone without using CSF analysis. However, one thing that's very important is patients who present with classic signs of aneurysmal subarachnoid hemorrhage, remember, worst headache of their life, if they have a negative brain CT, they should really still get a lumbar puncture because we don't want to miss a brain aneurysm. So when we talk about sensitivity and specificity, remember sensitivity is ability to rule out a disease. Specificity is the ability to rule in a disease. So if you remember the word snout spin, sensitivity is the ability to rule out a disease. Specificity is the ability to rule in a disease. So imaging, how do we image brain aneurysms? Well, one way we could do it is CT angiography. And this has many advantages over digital subtraction angiography as it is a non-invasive test. It has increased availability. This is available at almost every hospital now. This has lower risk because it's non-invasive, easier access. We're accessing the venous system, not the arterial system. And it takes a shorter time to do this test. So if you have an unstable patient, that could be a benefit. However, CTA has one critical flaw, and that is its sensitivity is less than 90% for aneurysms 3 millimeters or less in size. So for small brain aneurysms, we can't really rely on CTA. The CT appearance of aneurysmal subarachnoid hemorrhage with a negative CTA should warrant a cerebral angiogram. So if there's aneurysmal subarachnoid hemorrhage on CT, but the CTA is negative, you still need a cerebral angiogram to look for those smaller aneurysms. So there was two concerns for missed brain aneurysms we discussed earlier, but I just want to discuss them again really quick. So if a patient comes to the ED with the classic signs of an aneurysmal subarachnoid hemorrhage, i.e. the worst headache of their life, and their brain CT is negative, you should still do a lumbar puncture for CSF analysis to make sure you're not missing a ruptured brain aneurysm. If you get a CT scan on a patient and there's an aneurysmal subarachnoid bleed pattern, remember that central distribution pattern we talked earlier on CT, but the CTA is negative, i.e. it shows no aneurysm, you want to get a cerebral angiogram and look for those smaller aneurysms. Now, CT and CTA are more sensitive for aneurysmal subarachnoid hemorrhage than MRI or MRA with one important exception, and that is if we're imaging for subarachnoid hemorrhage 5 days after symptom onset. And why is that? Because 5 days later, those blood products disseminate and they're hard to see on CT. However, 5 days later, we start getting things like this, iron deposition, which is picked up on gradient echo sequencing and allows us to see subarachnoid hemorrhage because it allows us to see iron in this subarachnoid hemorrhage within this sulcal region of the brain. Again, it is this iron deposition that allows us to detect this subarachnoid hemorrhage days after symptom onset. Again, MRI is typically better 5 days after symptom onset than CT. MRI can also determine non-aneurysmal sources of subarachnoid hemorrhage, including cavernous malformations, dural venous sinus thrombosis, and spinal cord vascular malformations. And we'll be discussing these at a later lecture. Here's another gradient echo imaging, again demonstrating this region of iron deposition or subarachnoid hemorrhage. Now, cerebral angiography is considered the gold standard for the detection of intracranial aneurysms, particularly the smaller ones, less than 3 millimeters in size. 3D rotational angiography is the optimal diagnostic method, meaning we do these studies now where we could do 3D rotational angiography and reproduce all these vessels three-dimensionally. Cerebral angiography has greater sensitivity for the detection of those smaller aneurysms less than 3 millimeters than either CTA or MRA. This has a very low risk too, less than 1% risk of systemic or neurologic complications from digital subtraction angiography. However, there's a 2.66% risk of aneurysm re-rupture during a cerebral angiogram performed 6 hours after the initial subarachnoid hemorrhage. Unsecured ruptured brain aneurysms have short-term rebleed rates of 4% within the first 24 hours and a 1 to 1.5% rate thereafter for each day the aneurysm is not secured. As we go into more long-term rebleed rates for non-secured brain aneurysms, this approaches 50% in 6 months and then drops to approximately 3% every year thereafter. But here's the thing, 50% of unsecured ruptured brain aneurysm patients who rebleed will expire. So that's a very high number. That's why it's very important we do not miss these brain aneurysms. Well, that pretty much covers everything I want to discuss today. Remember, this is all covered in the book. If you value the content of this lecture, please be sure to hit the like and subscribe button. And thank you very much for your time.